Hi, my name is Dr. David Rubin. I'm from the University of Chicago. On behalf of CME Outfitters, it's my pleasure to invite you and to welcome you to the program that we've put together for patients called Who's in Charge, You or Your Crohn's Disease? I'm really looking forward to a conversation with my very good friend, Dr. Bruce Sands from Mount Sinai Hospital in New York City. Dr. Sands and I will be discussing management of Crohn's disease and, very importantly, an update on new guidelines that have been published related to the management of Crohn's disease. We both feel that it's very important for patients to understand these guidelines and certainly to understand the advances that have occurred in managing Crohn's disease so that you can take charge of your Crohn's disease, or if you're a loved one who has a family member with Crohn's disease or someone that you care about, you'll understand how to support them. And we hope that you'll find enough information during this program to have an informed conversation with your healthcare team and the people who are managing your Crohn's disease when we're finished. Well, one of the challenges we know is that many patients are concerned about surgery, and we certainly appreciate that. Although a surgical decision might be obvious from the perspective of the healthcare provider, the gastroenterologist, or the surgeon, we recognize it's never an easy thing for a patient or their family. And so we wanted to talk briefly about what that means. Surgery is sometimes indicated for Crohn's, and as Dr. Sands mentioned earlier, it sometimes is the best way to get the disease under control, recognizing that very often Crohn's disease may be present and progressing before you're diagnosed, before you even have any symptoms. So by the time we start therapy, there's some scar tissue, or there may even be a partial bowel obstruction. And therefore, sometimes a limited resection of the bowel is the best treatment and the best way to get the disease under control. I don't mean to minimize this, except to say that one of the main advantages of doing so is that it's much easier to prevent the disease from coming back than to try to treat it when we're starting behind the game. And so we've learned an awful lot about how to monitor patients after surgery and how to use our treatments, many of the ones that you've heard about already, to prevent the disease from coming back. I often tell my patients that if they need a limited resection of their bowel for their Crohn's, our goal is that this should be the only surgery they ever have. And they feel well when it's over, and we move forward together. There are many different reasons to have surgery that aren't due to bowel obstruction, but are rare, like having bleeding, or quite rare would be to have a cancer of the bowel. That is not something that we worry as much about at all, and we certainly keep an eye out for. So there are different types of surgeries patients have. Of course, patients are always asking, are they going to need a permanent ileostomy or a stoma, where the bowel is brought up to the skin? That's uncommon. When it is done, it is often providing great relief to the patients, and we have many successful patients who are living very healthy lives with that anatomy. More commonly is where they remove a segment of bowel and sew the healthy tissue back together on the inside. The important thing to remember is that, as we've mentioned, the inflammation may come back in some patients, and you won't feel it right away. So you have to have a monitoring strategy. You'll feel great, but we want to keep you that way. And so any approach to surgery in Crohn's disease also includes a strategy for prevention and monitoring afterwards. A more common strategy of surgery, or at least use of our surgical colleagues, has been to do what's called an exam under anesthesia. Now, what that means is that if there's perianal Crohn's disease, or some area that's too uncomfortable to be examined in the regular way in the office, they use anesthesia to make you comfortable, and then they can do a careful exam and either drain an abscess or help clarify a fistula tract. So the term exam under anesthesia is a type of surgery, but it's an outpatient procedure in most cases where you're cleaned up, you feel better when it's over, and then the medical therapy will work better. So there's some different ways that we work together with our surgeons. The main message we'd like you to understand is that talking about surgery is not meant to be the very last thing that we do. It should be partnered as part of all of our treatment strategies and all the medicines that you've heard about already today. So we're going to move through this because we have lots of great questions from our audience. And while I'm looking at the questions, I'm going to ask Dr. Sands to tell you a little bit about using checklists to manage your disease. There are a couple of checklists out there, and if you can just talk to them about that, I'm going to look at some of these great questions we have.
Sure. Yeah, checklists are a way of making sure that your doctor is doing everything that he or she can do to maintain your good health. And there are a variety of things that would include, and that might include vaccinations of various sorts to prevent infections while you're on medications. That might include cancer prevention things such as pap smears, skin screening for certain medications, colonoscopy if you are at risk for colon cancer, for example. And then your bone health has to be attended to. You shouldn't be smoking if you have Crohn's disease, because that makes the disease worse, and also checking for mood disorder, depression. So there are a checklist of things that should be covered, and there are such checklists available from the Crohn's and Colitis Foundation, also from the Cornerstones Foundation that Dr. Rubin directs. And checklists are used widely in all kinds of industries, such as the airline industry, to make sure nothing is missed. And that's exactly how we use them too.
And both of these checklists are available on the CME Outfitters website under the Patient Information tab. So you can get these as well as access to other great tools and previous educational programs. So Bruce, there's some great questions here. What an engaged audience we have, and I'm very grateful for these wonderful questions. Let me start with a couple questions just about inflammation. First of all, can Calprotectin be used in people who have ileostomies?
That's a wonderful question. Calprotectin is potentially useful for patients with ileostomies because really calprotectin is measuring the presence of a certain kind of white cell called neutrophils, which are present whenever there's activity of Crohn's disease. So I think it could be used to monitor.
And I've used it there. So that's the stool marker for those out there who didn't remember all that.
Yeah.
Somebody else said CRP can be a marker of inflammation. That's the blood test.
Yes.
Anywhere in the body. So why do we use it for IBD if it's not going to tell us that it's just the IBD?
Well, it's true that the blood-based markers could be from an infection anywhere, it could be from inflammation anywhere in the body, but in the situation where we're reasonably sure that there is no other infection or inflammation, we can use it as some sort of indicator of the inflammation in the bowel, but it is imperfect because of that.
Why is the elemental diet only listed as an option for children? Doesn't it work in adults?
Well, in fact, there is evidence that not just elemental diet, but semi-elemental or more formula diets that are more palatable might actually work for adults as well. It's just that a lot of adults don't really want to take it, and as we said earlier, it works while you take it, and then when you stop taking it, if you don't otherwise modify your diet or your medications, you may be right back where you started from.
And there's obviously a lot of work going on now to try and understand more of the diet and the gut microbiome interactions and how we might use these. Maybe not always for induction, but maybe some modified version in the future for maintenance.
I think we will be.
And the key message for anyone who's considering more dietary approaches to their management is what we've said all along, which is monitoring. Make sure you're achieving your target of control. There's a question here just about how do you know that these new drugs are safe? This is a common question. We get asked this all the time in clinic. It's a completely reasonable thought that someone has. We are always hearing about a therapy that we thought we knew all about, and then there's something new. So how do we have this conversation with patients, and how can we reassure them?
Yeah, it's an excellent question and not a very easy one to answer because, of course, all drugs that go through the FDA approval process have had more than 1,000 patients who have gotten the medication and hundreds who have gotten it for a couple of years. And so there's a fair bit of evidence, but we don't always have 10,000 patients treated. But what we can do in many cases is these drugs may have been approved for other indications such as rheumatoid arthritis or psoriasis, and we would have some indications of the safety profile of the medication from those conditions as well, where many thousands, if not tens of thousands of patients would already have been treated.
And as you already mentioned, of course, our old-fashioned therapy, steroids, we know remains the most dangerous treatment we keep seeing in all the studies that have looked at it. I'll answer this question. Somebody asked about CBD products, so cannabis-related products for pain and inflammation for Crohn's. as I'm sure the audience knows, this is a therapy option that is available in many states now legally. And in fact, we recognize that cannabis may play a role in helping with bowel cramps or pain or nausea or appetite. But we also recognize that so far, there is not evidence that it controls the inflammation. The one study that's often quoted is from colleagues of ours in Israel, where it showed improvement in symptoms, but didn't show that the inflammation was under better control, and that's often misunderstood. So in my own practice, I can't speak for all my colleagues. I actually embrace it as a complementary therapy. It's not meant to substitute other treatments. And the general theme again tonight is we want to monitor and make sure we're achieving our targets. So I think that you can go to the Crohn's and Colitis Foundation website and read more about that. There's been some extensive new positions and discussions about that important topic. One more question I wanted you to address for us tonight is, how does Entyvio work? Is it actually suppressing the immune system? Would it affect the body's ability to fight infections in the gut? What can you teach us about that?
The best understanding of how Entyvio works is that it's actually blocking the white blood, certain populations of white blood cells that are targeted for the bowel, and keeping them from entering the bowel. And those are potentially the troublemaker cells in the inflammation. So you can think of it as a roadblock. Basically, you're interfering with the zip code that targets the cells into the bowel. So in theory, while that would potentially increase the risk of bowel infections, you don't actually see that showing up very much in very large data sets looking at the occurrence of infections. Maybe just a slight increased risk, but not very much, which is a little surprising.
It's very interesting. And we certainly have seen enough patients on it now that we would have expected a stronger signal if that was going on.
Yeah.
I'll answer the last question and then I'm going to wrap, and I wish we could get to everyone's questions, but I think that this has been a very engaging program, and we're grateful to all of you for sending your questions in. The question I'm going to answer is, somebody asked about fecal transplantation. We're now actually calling it intestinal microbiota transfer or transplantation. The idea here is to take stool or a stool slurry from somebody who's healthy and to prepare it, screen it properly, and then to put it into the bowel of somebody who has a disease, in this case Crohn's disease. It is something that we know works for people who have an infection called Clostridioides difficile. But in Crohn's disease, we haven't yet seen a signal that supports its use as a primary treatment. And in the guidelines, they did not embrace this as a treatment with good evidence. There are many reasons this may be, and in ulcerative colitis, we have a little more evidence. But one of the challenges is that we don't know what the perfect stool should be that we do this for, and we don't know enough about the safety yet for this. So you can look up DIY fecal transplants, but they're not recommended, and I would caution you against doing that. So with that, I want to just wrap. I want to specifically thank my partner here tonight, Dr. Bruce Sands from the Mount Sinai School of Medicine. I also want to thank the CME Outfitters crew for putting together this wonderful program, and I would refer you to their website and their Gastro Hub for Patients. So if you go to the website, navigate your way to the Gastro Hub for Patients for this program, as well as for some of the tools that we shared with you this evening, as well as for other programs. A special thank you to the patients who recorded audio clips for us and participated in the preparations for this program. And most of all, I want to thank all of you for joining us today for this program, and all of your family members out there who are caring for you and who care about you. I hope that you found this helpful, and I hope the next time you see your care team, you can ask them some of the questions that came up tonight so that you'll all be on the same page. I wish you the very best.